Thank you. Good morning. All right, so without further ado, I'm Junaid Siddiqui, and I direct the Atypical Parkinsonian Disorder Clinic, and I'm going to talk about Parkinsonism, something I'm very passionate about. So some disclosures and the plan today. So talk about Parkinsonism, try to clarify what Parkinsonism means. So I can be saying some word, but it means something else, and the other person who's on the other end thinks I'm saying something else. So very important to get the words right about Parkinsonism. Recognize Parkinson disease more comfortably, and the 4 major atypical Parkinsonian disorders, and try to get through some of the Parkinsonian disorder treatment. So we'll talk about Daisy. This is a 68-year-old right-handed female, 4 years history of tremor in the left hand, and recently started having tremor on the right side. She's still working as a cashier. She denies any memory problems, no balance difficulties, no lightheadedness on standing up. She has a reduced sense of smell going on for a long time. She has constipation and has acted out her dreams. She struck her husband during sleep, and now they sleep separately. On examination, she has a rest tremor in her right hand. She has a reduced blink rate. She has rigidity and bradykinesia with a reduced left arm swing. Her balance was normal. What do you think is going on? Very good, Parkinson's disease. So here is a video that is actually not of Miss Daisy, but somebody else. So you can see the clear asymmetry, even in the postures. Look at the left toe, that's going to call a striatal toe. And then the rest tremor, that seems to be more on the left leg than the arm. When it's there, you can appreciate it. And this is how she walks. So reduced arm swing seems to be more on the right side. There's a rest tremor in the right hand. Reduced stride length. She stoops forward, and then when she turns, she takes several steps to turn. It's called turning and block. Okay, so this is, and because she's still walking without any help, so she has very good or relatively intact postural reflexes. So what's in a name? Is it Parkinson's disease? Is it Parkinson disease? Is it Parkinsonism? Is it Parkinson? Is it atypical Parkinsonism? Is it Parkinson plus? Is it Parkinsonisms? So I've heard all those things in the past, so we're going to try to clarify. So historically, we've been using the UK Brain Bank criteria for diagnosing Parkinson's disease and Parkinsonism. So Parkinsonism, and I use this acronym, I like it. So akinesia is actually bradykinesia. So we use A there. So tremor, rigidity, akinesia, and postural instability. It's not the best acronym to use when you're explaining this to patients. But one thing is important to know that akinesia or bradykinesia is essential in the diagnosis. So you have to have bradykinesia to start with, and unless you have that, you cannot really build on anything else. So the other conditions, you can have tremor, rigidity, postural instability, any 2 of the other 3. So this used to be the UK Brain Bank criteria. Now the MDS criteria since 2017 has reduced the load, and I've made this acronym myself, ART. This is a better sort of thing. So ART of diagnosing Parkinson's disease. So akinesia is essential. Rigidity and tremor could be the 1 or 2 other things that you can have. So then you have this Parkinsonism. And the example I give to patients and some of the medical students is like a headache. You know, headache is not a diagnosis. Headache is something that is present, a symptom of something else, right? Similarly, Parkinsonism are features coming from an underlying disease, like Parkinson's disease, an atypical Parkinsonian disorder, vascular, whatever you can imagine. But Parkinsonism is not a diagnosis. But knowing Parkinsonism exists, then you can look for the underlying cause. So, so just like that, you see that the ART, akinesia, rigidity, and tremor, and then that could be from Parkinson's disease, DLB, PSP, CBD, MSA. We'll go through some of these conditions and others, and that's Parkinsonism. So causes of Parkinsonism. There are primary Parkinsonian disorders, and there are secondary conditions that can cause Parkinsonism as well. The condition that primarily cause Parkinsonism can be typical or atypical. The typical Parkinsonian disorder is Parkinson's disease. When somebody is having evolution of symptoms that is not typical for Parkinson's disease, that means they may have an atypical Parkinsonian disorder. Okay, and that includes the four big bad conditions, so the PSP, DLB, MSA, and CBD. And then there are secondary causes, and I sort of made this distinction myself, non-inflammatory causes like NPH, drug-induced Parkinsonism, vascular functional Parkinsonism, and inflammatory causes like autoimmune and paraneoplastic. This is a sketch my 16-year-old son made. And now, neurodegenerative Parkinsonian disorders. So there are synucleinopathies and there are tauopathies. These are protein problems, okay, protein aggregates that accumulate in cells causing dysfunction. So synucleinopathies can be neuronal, and the examples are Parkinson's disease and DLB. They can be glial, like supportive cells, that MSA and PAF or primary autonomic failure. And there could be tauopathies causing the PSP or the CBD. So it's important to recognize that these are actually different conditions. So like if somebody has PSP, the reason they don't have anosmia is because it's not a synucleinopathy. So anosmia, REM sleep behavior disorder, these are characteristics of synucleinopathies. So synucleinopathies. So the neuronal or the Lewy body diseases, including Parkinson's disease and DLB, and they're glial. They can be central, like MSA, or they could be peripheral, like primary autonomic failure. The tauopathies. They can be primary tauopathies, secondary tauopathies. What we're interested here is this guy, 4R, PSP and CBD. Okay, so but the thing is that all these conditions can actually cause Parkinsonism and may appear like an atypical Parkinsonian disorder. Even Alzheimer's disease can present with like PSP or CBD. Okay, chronic CBS, sorry. Okay. So this is a new staging system that's currently being used just for research purposes, but I imagine that it's going to be more important as we go on. And it's a mouthful, neuronal alpha-synuclein disease integrated staging system. What they do is they're using these biological anchors, and they're using these clinical features and then functional impairment resulting from those conditions. So biological anchors include, now we can detect the alpha-synuclein in the skin, in the CSF. So alpha-synuclein can be detected in the CSF. That means S is positive. S is for synuclein. Neuronal alpha-synuclein is positive or negative. Dopaminergic neural dysfunction detected by a DAT scan. And genetic status. So you can, so G plus or minus or D plus or minus. And then, mild, moderate, and severe symptoms, or mild, moderate, and severe functional impairment. So the MDS diagnostic criteria for Parkinson's disease, and all this information is actually available, elsewhere. So I'm not going to spend too much time on this, but there are core or essential features, which is the ART, akinesia, rigidity, and tremor. There are supportive criteria, including levodopa response, levodopa-induced dyskinesia, rest tremor, olfactory loss, and there are absolute exclusion criteria. You're seeing a patient who has Parkinsonism, you're thinking about maybe this is Parkinson's disease, but then you start seeing these like cerebellar abnormalities. Think of MSA, there's vertical gaze abnormality, think of PSP. Symptoms that are very quickly progressive or not, or they're very static. And then red flags. So clinically established Parkinson disease, and when people have Parkinsonism, there is no absolute exclusion criteria, there are no red flags, and there are at least 2 supportive criteria. And it can be clinically probable when they have Parkinsonism, there is no absolute exclusion criteria, and the balance between the red flag and the supportive criteria but no more than 2 red flags. So the typical story, this is typical Parkinson disease. If it is not typical Parkinson disease, that means it is atypical. So we have to make sure that we understand the natural history of Parkinson disease. It is a very, very slowly progressive condition, okay, and it spans over decades. So people can have non-motor symptoms even before they present with tremor, stiffness, or slowness, and that can go on for years, like hyposmia, fatigue, depression, REM sleep behavior disorder, constipation. They can have tremor, that is usually the presenting symptom, or the Parkinsonism, okay? Anxiety, dyskinesia after about 5 years or so of starting medications, autonomic dysfunction, freezing of gait over 15 years, and then starting significant cognitive dysfunction and balance difficulty. And by the end of the road, 100% of people are wheelchair bound, and 85% of patients have dementia. And then, of course, they can have punding and dopamine dysregulation syndrome anytime during this course. So that's the typical story of Parkinson's disease. So if you're seeing somebody who does not follow this slowly progressive course, that means you have to look for some of the red flags in Parkinsonism. And in general, you have Parkinsonism, but you see a rapid progression of disease, or you have a positive family history, or you have an abnormal MRI finding, or you have the onset of symptoms is before 50 years of age, or they have these eye movement abnormalities, double vision, poor levodopa response, freezing of gait, requiring assistance within the first 3 years. So all these are like motor red flags, and cognitive aphasia, apraxia, hallucinations, significant cognitive fluctuations, and some of the autonomic dysfunction, of course. So you have to look for these red flags actively. You see any patient with Parkinsonism, you have to actively ask for these red flags. This is my approach to treating Parkinson's disease, and of course, as you see more and more Parkinson's disease patients, you develop your own. So I try to figure out if somebody has early disease. All they're looking for is a diagnosis, some answers about what's going on with them. So if they're not troubled by their symptoms, I don't think they need any medications, because I tell them that the patient is going to tell me when they want medications, because the medications we have available, they're not curative. They are symptomatic treatments. So the only 2 reasons somebody would take those medications is, number 1, they are troubled by their symptoms, or number 2, the medications are helping their symptoms. So if you don't have, one or both of these things, then they don't need to take those medications. So that's what my spiel when I see patients. So counseling about what Parkinson's disease is, sometimes giving them the bigger picture. Okay, you have Parkinsonism. It is from a neurodegenerative condition, but especially if they have Parkinson's disease, I actually give them this entire story that, you have Parkinson's disease from it could have been an atypical Parkinsonian disorder. And I tell them about the atypical conditions before, telling them you actually have the best form of Parkinsonism, so that makes them feel better about what their diagnosis is. So instead of, you have Parkinson's disease and that's it, so they say, okay, this is the end of the world, that's it. So that's my approach to so early disease, you counsel them, tell them about research studies, and tell them to exercise. Aerobic exercise actually improves tremor, stiffness, and slowness, and we have accumulating evidence it may actually slow down the disease. Okay, so exercise, moderate symptoms, you can offer them to medications. They start having fluctuations with time. So you adjust medications, you offer them intervention like DBS. And you have advanced disease, you continue to adjust medications, and you think about palliative care. So when you see a patient with Parkinson's disease or any atypical Parkinsonian disorder, you need to figure out what is the most troublesome symptom. Are they motor symptoms? Are they autonomic? Are they neuropsychiatric symptoms? And I wonder if you can see all those things. So like a motor, tremulous patient, off patient, frozen patient, dyskinetic patient, dystonic patient, autonomic symptom, lightheadedness, orthostasis, constipation, urinary insufficiency, erectile dysfunction, neuropsychiatric symptoms, anxiety, depression, psychosis, hallucinations. So this is my approach to thinking about like my mental sort of a process of thinking about, this is a patient with Parkinsonism, is it Parkinson's disease or something else? Is if they have an atypical, if they have a typical course, it's likely Parkinson's disease. If they have an atypical Parkinsonian disorder, like they have early falls or early memory problems, do they have dystonia, dysautonomia? If they have dysautonomia, it could be MSA. If there's no dysautonomia, it could be PSP. If they have a lot of memory problems before the falls, do they have visual hallucinations? If they have visual hallucinations, it's likely DLB. And if they don't have visual hallucinations, they have significant cognitive impairment, and they have asymmetric Parkinsonism, I think they have CBD. I was in Austin last week, and there was a DreamCon going on. This guy was dressed up like a cartoon character, so we thought took this picture. So we're talking about Bob. He's a 68-year-old male. He has tremor in the right hand. He has slowed down. He has progressive shuffling, and now he's tripping and using a cane. He's having trouble with his memory, seeing shadows within the 1 to 2 years, but getting more frequent. There's severe constipation. He's acting out his dreams at night. Examination shows an asymmetric Parkinsonism, postural instability, and orthostatic hypotension. What do you think is going on? Thinking about those things that we spoke about. Typical or atypical? Atypical. If they're having memory problems and they're having visual hallucinations, so REM sleep behavior disorder is there. That's the part of the synucleopathy, but they have hallucinations. That means it's likely DLB. So DLB recognition. So you have, and of course, like again, these criteria are available online, so I'm not going to dwell too much on them. But there are central features. You have to have dementia or cognitive impairment. There are supportive clinical features. There are core clinical features, and something similarly biomarkers, the DAT scan being positive and stuff like that. So you can. So you have, you can say possible, probable, and then DLB less likely based on how the combination of these criteria. So Lewy body disease, it's a spectrum, Parkinson's disease and DLB, right? So here's Robert. He's a 58-year-old man. He has been having fainting spells for the last 1 year with frequent falls. Now he's on a wheelchair. On questioning, he has had erectile dysfunction for 2 years and urinary incontinence. The sense of smell is normal, but he acts out his dreams. And he has symmetric Parkinsonism on examination, and the head is bent forward when you see him. What do you think is going on? Yes, MSA, good. Well, why? So the question is why MSA? So he has early balance difficulty. Yes, so that's atypical. Yes. Now he also has orthostatic hypotension. He is passing out from standing up. So severe autonomic dysfunction. He has erectile dysfunction. He has urinary incontinence. Okay, so that means there is dysautonomia going on. So early falls, that's atypical. Dysautonomia going on, that is MSA. Okay, and MSA is a synucleopathy, so you can still have REM sleep behavior disorder because it's a problem of the synucleus. That's the synuclein. Anosmia, REM sleep behavior disorder. So if it's a neuronal synucleinopathy, DLB, MSA, DLB and PD, they have anosmia. In MSA, they don't have anosmia, but they can still have REM sleep behavior disorder. So MSA patients can have a variable combination of progressive Parkinsonism, ataxia, falls, and dysautonomia. Okay, we use this unified MSA rating scale, and then if somebody has MSA-P and they have urinary retention and they can actually have sleep apnea, that means there's a poor survival, poor indication. Cognitive dysfunction and dementia, look for other causes. So people with MSA, they don't usually have significant cognitive impairment when you see them. So that's why, if you remember my flow chart, so if somebody has falls more than memory problems, you think of PSP and MSA. If they have more memory problems, think of DLB, CBD. So the question is, do we see mixed picture? Yes, all the time. Yeah, so that's why we don't depend on just one thing. It's like, you ask for all these things and you put them together, you try to do the best. And even with that, we still make mistakes. Okay, we're still unsure. So because a lot of these conditions, we diagnose them with like a syndromic diagnosis, but they tend to have something else, right? There was a study in which there was a diagnosis of Parkinson's disease, but post-mortem, only 60% of the patients actually had Parkinson's disease. Yeah, so even with Parkinson's, which is the most common, we think that we are good at diagnosing Parkinson's disease, so it's not like that. This is the best we can do in terms of trying to come up with, clinically. So there are some radiological features in MSA. You don't see them all the time, but it's worth looking for. It's called the putaminal rim sign, okay? And then, of course, the more famous one, if I can get this on. I don't know why it's not working. Okay. It's called the heart cross-bun sign. So there are MSA phenotypes. Before they used to say the olivopontocerebellar atrophy, Scheidegger syndrome, but they sort of done away with that, those distinctions, and they just say it's MSA-P, where P is for Parkinsonism. They have dysautonomia, they have cerebellar dysfunction, but they have a lot of Parkinsonism. Rigidity, bradykinesia is much more. And a lot of times people with MSA-P get diagnosed with Parkinson's disease until they start falling and they have dysautonomia. And MSA-C, which is MSA cerebellum, so cerebellar dysfunction, a lot of ataxia, nystagmus, dysarthria, but everybody develops everything. So dysautonomia, balance difficulties, erectile dysfunction, urinary incontinence, cerebellar dysfunction, and of course everybody has Parkinsonism. This is my sister. She painted this for me. So we're talking about Eddie. He is a 58-year-old man, previously healthy. He now has abrupt onset of spontaneous falls. He stands up, he falls backwards. Now being forced to stay on a wheelchair. So he has good strength, but he keeps getting up and falling backwards. He can't stop himself from standing up and getting in these situations where he falls. He has been behaving erratically and gets angry very quickly. And on examination, there is no tremor, there is no orthostasis, and he does not act out his dreams. What do you think is going on? He has PSP, progressive supranuclear palsy. Okay, so early falls, atypical, yes? No dysautonomia, no REM sleep behavior disorder, no anosmia. So he does not have an alpha-synucleopathy. He has a tauopathy. Early falls, without dysautonomia, he has PSP rather than, if you remember that flow chart. So these are some videos. This is the middle guy. I saw him in the clinic. As you can see, he has this surprised look. People have this hyperactive frontalis, and they have this surprised look. And as soon as I entered the clinic, he actually jumped out of his chair and fell backwards. I had to catch him. Okay, so he has this something called a rocket sign, because they have this impulsive behavior with PSP that they keep getting into these situations where they tend to fall. The guy knows he's not supposed to get on a ladder. He keeps going on the ladder, on the chair, and keeps falling. Okay, so that's called a rocket sign. That's an impulsive behavior. Okay, and then here, this is like more classic. So I'm looking for eye movement abnormalities. Saccades are the fast movements that we make from going from one point to another. These are normal movements. So his horizontal saccades are normal, but his vertical saccades are very slow. And the slow pursuit, the smooth pursuit movement is actually impaired vertically. He can't look up or down. See that? So he was able to follow the pointer to the right or left, but vertically he was unable. So he has vertical gaze palsy. Now, how do we know if it's nuclear or supranuclear? If we can overcome the deficit by head movement, that means it's supranuclear. If you hold his head, and that's how I do, so you hold the head and you ask the patient to continue looking at my nose, and then you pull the head up and down. If they're able to keep the eyes on my nose, and now by moving the head, I can see that he can actually, eyes are staying there and he can up and down. That means it's supranuclear palsy. But if the eyes move with the head, that is a nuclear or infranuclear. So that's why it's named supranuclear palsy. Progressive supranuclear palsy. So that is the sort of a main character. And then this gentleman here, he has another sign. So we're asking him to clap 3 times. So he keeps clapping 4 or 5 times. That's called motor perseveration. That's also a clinical sign in PSP. Okay, it's called the applaud sign. So you clap, but he keeps. Okay, so 4 or 5 times. So they can't stop at the same. So this motor perseveration is called applaud sign. So PSP, of course, not everybody develops all these things in the same rate. PSP has its own phenotypes. There's the Steele-Richardson phenotype, which is the more classic PSP, where people have early balance difficulties, they fall backwards, they have vertical gaze abnormalities, they have this subcortical dementia. So that's the Richardson syndrome. And then there's a non-Richardson syndrome. So a lot of times patients end up having diagnosis of Parkinson's disease, but then they start falling up quickly. Okay, so that's PSP-P. Okay, they have Parkinsonism, but a lot of eye movement abnormalities, not a lot of falls early on. That's oculomotor. SL is speech and language. PGF is progressive gait freezing. PLS is primary lateral sclerosis. And PI is postural instability. CBS is corticobasal syndrome. So PSP patients can actually present with corticobasal syndrome. And PSPC is when they actually have cerebellar dysfunction, in addition to significant. So a lot of overlap, as you can see. So not everybody with PSP will present with the textbook picture because of these phenotypes that are increasingly being recognized. So some of the classic radiological features, the hummingbird sign, you can look for it, but this is actually more specific for the Richardson phenotype. So if you have some of the other phenotypes, you won't be seeing these things, okay? And there's actually a midbrain atrophy, and the pons is actually intact, that the pons are fleshy, but the midbrain becomes smaller and gives this appearance of a hummingbird. So Kelsey is a 68-year-old right-handed woman. She's unable to use her left hand and is increasingly relying on her right hand for all activities. Her left hand reportedly fiddles with and interferes with what she's doing, as if it has a mind of its own. She has more trouble keeping track of her appointments and is unable to manage her finances and driving, and is unable to brush her teeth. He does not report weakness as though. So there's no weakness, but she's unable to use her hand to brush her teeth. What is going on? Yeah, CBD, alien Hansen, that's pretty good. So this is not Kelsey, but she is another patient that I saw. So as you can see, she is seated on a chair, so she does not have significant balance trouble. She has reduced blink rate, and she is not moving very fast, so she has what looks like bradykinesia. And if you can look at the left hand, it seems to be like elevated like this, and she keeps using her right hand to bring it down or use it like that. So that's the alien limb phenomenon on the left arm. It's called limb levitation or alien limb phenomenon. And here I'm demonstrating a sign. So whenever she is approached with something, she has to grab it and fiddle with it. It's called utilization behavior. So you put a few things in front of them, and every time they have to sort of pick it up and play with it. It's called utilization behavior. It's a frontal release phenomenon. So you put your arm out, they keep shaking your hand. You put the pen out, they keep, using it and picking it. She's done it before, but she keeps on doing it. Okay, so she has corticobasal syndrome, very asymmetric Parkinsonism. Hubert Fernandez was here a minute ago. So he is the one who told me that the only thing that is more asymmetric than Parkinson disease is CBD. So corticobasal degeneration is the progressive asymmetric Parkinsonism, severe rigidity. They may develop spasticity, dystonia, alien limb phenomena presenting with loss of function of the limb, early cognitive decline, myoclonus, and falls. Okay, corticobasal degeneration. And there's an alien limb phenomenon which can be classified like a frontal variant. There's a posterior variant. There's a colossal variant. The frontal variant, people have this groping, grasping, and other release phenomena. There's a posterior variant where there's a limb levitation. So your arm is like this, keeps on going up like this, limb levitation. There's clumsiness or apraxia. So apraxia is inability to do a learned activity without weakness. So you can't explain, okay, I can't use my right hand to brush my teeth, but you examine the right hand and the strength is perfectly normal. So there's no weakness. So there's no way, there's no sensory loss, there's no weakness, but they're unable to use the hand, so they lose their ability to do the learned activities like that. So that's called apraxia. And foreignness, so they sort of neglect the left arm or the right arm as if that's not their own. Okay, and intramanual conflict is when people have, I'm trying to write with my right hand, and the left arm sort of keeps on, interfering what I'm doing. That's called intramanual conflict. That's a colossal variant of an alien limb phenomenon. So Parkinson disease and other Parkinsonian disorders, so you can talk about tremor, wearing off, levodopa-induced dyskinesia, freezing of gait, orthostasis, constipation, REM sleep behavior disorder, depression, anxiety. So many things to look for in patients who have Parkinsonism, trying to figure out what is bothering them the most, and then you sort of, focus your attention on that. But always remember the simple things. Education and counseling about Parkinsonism is extremely important, because most of the anxiety patients have is actually not knowing what they have plus what the future looks like. But if you give them that information, that sort of relieves a lot of that anxiety and helps you take care of them better. So always, have a low threshold to refer patients for physical therapy, occupational therapy, speech therapy. Advice about exercise, like I said, exercise, actually aerobic exercise, not only improves tremor, stiffness, and slowness, and we discovered that at the Cleveland Clinic by Jay Alberts. Actually, he was the one who discovered this. Aerobic exercise, they compared patients with Parkinson's disease who took medications, and then with a cohort of patients that did not take medications, only did aerobic exercise. And we found that patients who had done aerobic exercise, the improvement in tremor, stiffness, and slowness actually was equal to the patients who took medications, with each dose of exercise lasting for several days. Okay, so definitely aerobic exercise as much as they can. Okay, and then referral to psychiatry and psychology, inquire about non-motor symptoms, and actually the non-motor symptoms may be more problematic than the motor symptoms. And of course, there are two higher centers of care about an opinion if you think that this may be something else, or you have higher level of care, or some research, like we like to do some research, so we have some things going on there. So the tremulous patient, if patient has Parkinson's disease and tremor is the predominant symptom, and they want this to be treated, if the age is less than 60, and this is my approach, and you can go back and forth, like it's not, So if it's younger, so age less than 60, that means younger patient, you can try a beta blocker, you can try an anticholinergic medication, you can try go on to amantadine, then try dopamine agonist, then try levodopa, and then in about 1/3 of patients with tremor predominant Parkinson's disease, their tremor does not respond to medications. So they have medication resistant tremor predominant Parkinson's disease. In those cases, you offer DBS. And if the age is above 60, then you don't offer the beta blockers or the cholinergic medications. You start with levodopa. You give dopamine agonists. You give monoaminoxidase inhibitors and offer DBS, of course. Patient who's wearing off, you start a medication and they're doing very well. After 3 years, 4 years, the medication is not lasting as long. If the, younger patients, you increase the dose and take the medication on an empty stomach because, as you know, levodopa competes with protein for absorption. So if you just make a simple adjustment, why don't you try taking the medication on an empty stomach? That may end up having more levodopa. So more frequent doses, dose fractionation, adding a monoaminoxidase inhibitor or a COMT inhibitor, adding dopamine agonist, acetylcholine, NDBS, LCIG, And if somebody is more than 60, you start with add levodopa, something similar to the other one. So levodopa-induced dyskinesia. So where is the problem and what is the problem? It's absolutely imperative that we understand that you take, medications, they start working, they have this peak effect, and they start wearing off. So if somebody has levodopa-induced dyskinesia, that means they're taking this medication and then they start having this, dyskinesia. You want to find out where it happens. Does it happen when the medication is peaking? It's called on state, peak dose dyskinesia. And is it an off phase dyskinesia, or is it an intermediate stage? Where in the scheme of things are they having these symptoms? And then this paper by Espay is very good, where they talk about peak dose dyskinesia and its location, and then so diphasic dyskinesia, usually the lower extremities. Pharmacodynamics of dopaminergic medication. Like I said, the medication take time to kick in. There's a duration of action, and then they start wearing off. And in early disease, you're taking a medication 3 times a day, and they start working in the morning, they never wear off, and they go to sleep, and they feel everything is fine and dandy, okay? But a few years later, then the peaks sort of separate a little bit. It takes longer for the medication to kick in, and it doesn't, the peaks are lower, they're narrower, they don't last as long, and there is, thank you, and then there is more distance between. So if somebody has peak dose dyskinesia, this is, my approach, you can stop the CMT, so essentially reduce the medications. But diphasic dyskinesias, you actually treat like off phenomenon. Freezing of gait can be more tricky. You have to decide if it's off-state freezing, on-state freezing, or unresponsive freezing. If it's off-state, you treat it like an off phenomenon. If it's on-state, it may be pseudo-on. That means the freezing may actually improve by increasing the medication at the cost of dyskinesia. And then there is true on-freezing, when the higher doses cause freezing, and unresponsive freezing. It doesn't matter the dose high or low, they still freeze. All right.
All right, thank you. Obviously, we have to give more information because we're never quite sure how long it's going to go or not go, but we'll have questions at the end. So Dr. Mayer is going to come here.